I want to talk specifically about the benefits of antibiotics in different situations. One of the areas that I'm particularly interested in, as I've said, is chronic respiratory illness like asthma and COPD. Now, I don't know how things are managed in Italy when people have chronic obstructive pulmonary disease exacerbations, but in the UK, we still have a bit of a problem where if anyone gets worse with their COPD and exacerbation, it's still a kind of almost automatic prescription of prednisolone and antibiotics. So, yes, we should be treating exacerbations with these two drugs. That's not a problem. There is evidence for doing that. But we know that people with COPD can exacerbate for other reasons. Is this exacerbation a new presentation of a bronchial lung cancer? Is it a pulmonary embolus? Is the breathlessness actually due to cardiac valve disease or due to a heart attack? There's lots of different causes, so it needs some thinking. But it also needs thinking, even if we think it's an infective exacerbation, about what the possibility might be. Recent work in the UK has shown that the vast majority of COPD exacerbations are caused by viruses, and that's probably not a surprise to you. There will be other factors that are very important that add on to this, like tobacco smoking, change in air temperature, air quality, psychological and physical stress. These are all important. But actually, the number that are caused by bacteria rather than virus is probably about a third. So in the vast majority of cases, even with COPD, it's probable that the cause is not bacterial. And whilst if it is, we would want to be supportive with an antibiotic course, we do need to consider what the options are. It's not absolutely clear-cut what we are to do, but there are things that can help us. The colour of the sputum. If you've got COPD, it's likely to some degree that you make sputum, you know how much you produce every day, and you know what the colour is. And one of the benefits in talking to people with COPD is that if they exacerbate, they will have a memory of what's normal for them usually and what happened last time. So changes in the volume, the consistency, and the colour of the sputum is helpful. Other things which are obviously very helpful are things like the C-reactive protein test. If this can be done at your desk with a near-patient testing kit, we also know from recent studies that a high CRPD is more predictive of a bacterial infection, and that can help you make a decision to give antibacterials. We also have nice guidance in the UK, for example, around the risk of pneumonia, where CRP, the C-reactive protein test, done near the patient can be helpful in our decision making. One thing that it might be worth highlighting here in relation to COVID, some of you may remember early on in the epidemic, when we didn't know a huge amount, that lots of people who were sick enough to go into hospital were automatically being given antibiotics. It's interesting that quickly, as the data started to emerge, a systematic review was done, and it turns out that even in those who were critically ill with COVID-19, they didn't have secondary bacterial infection. I think this was a bit difficult for us all to understand, but that's the evidence. The real problem from COVID-19 was the virus itself and not the secondary bacterial events which didn't appear to be happening. So let's move on to some of the more common specific situations where you need to make some decisions about whether or not to give antibiotics. I mentioned earlier when talking about the epidemiology that sore throat is probably the condition that's most likely, but still unlikely, to move from being a mild viral upper respiratory infection into something more significant like peritonsillar disease or tonsillar abscess. So what we've got in this situation to help us decide whether or not to use antibiotics is something called the Centaur score. Hopefully many of you will have come across the Centaur score. This is a score which I find particularly helpful because I can share it with patients. I have it as an app on my phone. When they come in, I find out their story, and then I punch the numbers into my phone, showing the patient what I'm doing, showing them what the significant factors are: the high temperature above 38, the evidence of exudate on the tonsils, how close are the tonsils meeting in the middle, do they have a cough. These are important features in deciding the risk of going on to have more serious disease. And when I'm completing this particular test on my phone, I can show a patient what happens to the advice if I put in or don't put in a particular parameter. This can be very helpful in educating them that there is a decision to be made about antibiotics or not. What I would suggest to you is that I've now been using the Centaur criteria for at least a decade. And I've been looking after respiratory infections for at least 2 decades. 2 decades ago, it was very difficult for me to persuade somebody that they didn't need an antibiotic when they had a horrible tonsillitis that was stopping them from going to work and was making them feel unwell. Today, it's much easier. As a result of a kind of national approach to education around the need for antibiotics and the harm of giving too many antibacterials, we have got to a situation where it's much, much easier to have these conversations. We now have the tools like the Centaur criteria, which help us to rationalize and explain and work with the patient with shared decision making about what to do now, what to do in 2 days, what to do in 3 days, so that they feel listened to, but also that if things don't turn out like we've said it would, there is something to do. There is an opportunity to come back and to get help. We've talked a little bit about otitis media, middle ear infection, usually much more a problem in children than adults, but of course adults do get it as well. There are some key features there that allow us to not give antibiotics, but also help us to decide when antibiotics might be more appropriate. A reasonable time period to wait to see what's going to happen is 48 hours. People can have temperatures with otitis media and not need antibiotics. It's only very high temperatures, maybe above 39 degrees, where we need to think about doing something. It is worth examining somebody after 48 hours of a middle ear infection or symptoms of it to look for a bulging tympanic membrane to see if it's perforated. In this situation, you would be more likely to give antibiotics and it would be supported by the evidence. Let's think about the situation with sinusitis. Here, evidence would recommend that we wait up to 7 days before doing anything in terms of antibiotics about sinusitis. This is a condition where the inflammation takes longer to clear, such that symptomatically people can feel relieved. And indeed, even after they've had this episode and they still don't feel better, it is recommended that we think about using a nasal corticosteroid for a few more days before we think about giving a prescription. It's very important, if you use a nasal corticosteroid, to ensure that you've taught the patient how to use it, because in my experience, most people tend to use it incorrectly, and it's pretty critical, as with respiratory inhalers, that the drug gets to the right place to do the right job. So with sinusitis, we actually can delay antibiotics a bit longer than some of the other respiratory infections, 7 days. Then we try nasal corticosteroids in the right way, and then we can consider antibiotics.